session will be very, very fruitful. And so just to cut the chase, let's just start. So I received this case, a 12-year-old Saudi girl in my clinic, where she came with her mother complaining of, maybe you could see it, this ill-defined, hyperpigmented, a bit hairy patch over the right cheek since many, many years, since her childhood. And now it's getting onto her. She's bothered by it, and she wants us to do something about it. So she came to our clinic, and I had my residents. They presented a straightforward case, and I told them, okay, what do you think? What are your differential diagnoses? I mean, who can tell me an idea of what's going on in this case? It's a simple case. So what do you think? Sorry? Okay. Well, then I came along because what we have is we have 3 or 4 clinics, and I go back and forth between the rooms. So when I came to see the patient, what I noticed that there was some sort of asymmetry over the face. You can see the asymmetry, and I was like, okay, that's interesting. And I was looking at the lips. Look at the lips. The right side of the face is a bit. There's some sort of asymmetry there, and it's somehow in a segmental fashion. I was like, okay, fine. There's something wrong here. The second thing I asked to do is to open the mouth, and this is what we found. There was a clear hypertrophy on the right side of the gingiva and missing teeth, and that was something interesting for me. See, as a pediatric dermatology, what we see is when we see a lump of manifestations together, the first thing we go to think of is could be a syndrome. But the question is what type of syndrome. That's the challenge here. We went through all of the differential diagnosis of syndromes that we could think of, and for the that shouldn't be like this. Anyway, for the record, what we did is I did a biopsy for a possible publication which came back to be Becker's nevus. I did as well an X-ray. I mean, there's some problems with the slides, I guess. What I did an X-ray panoramic radiograph and showed missing teeth. Not only loss of teeth, there's some sort of missing teeth there. And we reached to a diagnosis called HAT syndrome. This is super rare. It's an acronym of something called hemimaxillary enlargement, asymmetry of the face, tooth abnormalities, and skin findings, which is mostly Becker's nevus. That's why I did the biopsy, just to prove that. It's considered a rare developmental disorder involving the first and second branchial arches. As I said, the Becker's nevus is the most common cutaneous manifestations of it. It starts early as it did in our patient. Males are more than females, but in our case, it's the other way around. We don't really know exactly the etiology of this syndrome. I've read quite a bit about it, and it has something to do with a segmental alteration. So I guess as we see that there's some sort of mutation in the progenitor cell early in the embryogenesis. So you have a rise to an altered clone, يعني في بعض الخلايا كده there's an altered في منطقة هذه معينة, which later colonizes and influences the embryogenesis, the morphogenesis, في الectodermal, mesodermal, فيبدأ التأثير in this segment, as we can see in McCune-Albright as well. It's the same explanation. This type of post-zygotic mutation in patients with HAT syndrome may result in genotypic mosaicism as well in both skin and bone, as we've seen here. Some might argue that this could be due to a viral or bacterial infection that could cause it. We still don't have a standardized treatment for it. It's mostly a multidisciplinary approach for this young lady. We called the plastic surgeons, the maxillofacial surgeons, and for us, mostly she was complaining she just came for this patch, and we don't have much to do with it. And Dr. Ahmed Riza is here, and he might, yes, I might need your insight on this, because Becker's nevus, it's always a difficult thing to treat regarding laser, but we're trying our best in this regard. I've seen this patient. You can take a look at it. I published this a while ago, and you can look at it. I had difficulties in this case because I've seen it 3 years ago, and I really wanted to go to the core of it and to know the exact gene. I didn't have the access to genetic analysis. Now I do. I tried to call them back because they're not from the same city. I think their social conditions were not very compatible with the appointments that we were given, but I will get to the bottom of this. I will know this gene. So this is the second case. Is a Saudi 14-year-old female from the south. She's not from the same city as where I practice, and she presented with these lesions since the age of 3 months. Of course, it grew gradually with time, and it was a bit itchy. And as you can see on dermoscopy, it's very clear that it's very well demarcated, irregular. You can see the hyperkeratotic edges with the erythema in the center. What do you think? What do you think this could be? Afwan? Okay, what else? Lichen? We debarked on could be some sort of segmental, discoid lupus, porokeratosis and stuff, and see the patient had denied having specific lesions before. Apart from topical emollients, she was never ever treated. She just came now. I mean, this is what we always face in such cases, that they reach an age where they decide that, well, we need to treat, we need to do something about it. So we did a biopsy, and this came back. It showed some sort of acanthosis and focal parakeratosis. And so we labeled this patient as linear porokeratosis, bravo. And now the challenge is, how do we treat such patient? It's always difficult. So what we did is I started on the patient on isotretinoin 20 milligrams. And after the first visit that came I think 2 months after, she came back with her parents. They were very meticulous. They're very compliant. I liked the parents. I liked the girl. They listened like literally to everything I was saying. So I do believe whatever she used to say. She only complained of mild dryness, as we expect from isotretinoin. The treatment was well tolerated. What she mentioned is there was a significant reduction in the itchiness only. That's the main complaint of hers, that she's always itching. Well, that's a good thing. يعني تحسنت شوي, the itchiness is better a bit, but upon re-examination there's some sort of improvement in the central erythema. There's no difference in terms of the size or the peripheral scale thickness. So what we did is we went back to the literature, and we thought to give topical atorvastatin 2%. So we added that, and 10 weeks later at the follow-up, the itching, well, it wasn't that big of a difference, or it already improved, but the scales did improve. Peripheral lesion pigmentation improved by a small margin. So you can see here in the dermoscopy, I mean, if you can go back fast, just for comparison, you can see here the edges under dermoscopy, and here is it was a bit better, sorry. So it wasn't very satisfactory, but yeah, yani, it was something. So what is porokeratosis? It's mostly a disorder of epidermal keratinization. So we need to understand what it is in order to try to think to what to do. Annular plaques with an atrophic center. The condition can be diagnosed through histological examination. That's what we did. I mean, for the residents, mostly it's fundamental to do correlation. That's what we did. I mean, it's fundamental to do correlation when you do histology and to prove such diagnosis. Why am I mostly concerned, and we should concern? Because of the misdiagnosis that we could have. Why? If we misdiagnose such patient, knowing that porokeratosis could have the risk of malignancy, squamous cell carcinoma, basal cell carcinoma, you might end up treating this patient with narrow band and increasing the risk, and that could be a problem. So ultraviolet light has been shown to exacerbate symptoms, and the worst case scenario is promote the neoplastic transformation of these lesions, so we need to be very, very careful. So in general, the first line of treatment is still retinoids. It wasn't very satisfactory in our case. Less than 20% of patients do have some sort of results. It's still debatable in the literature whether topical statins are beneficial to patients. It's known that cholesterol is an essential component of the keratinocyte cellular composition, and its reduction through statins is theorized to induce keratinocyte apoptosis. So the atorvastatin may have resulted in satisfactory results, but in our case it wasn't that much. But still, I mean, we're thinking of publishing this case, but even the negatives we need to show that it's somehow in a negative fashion. Okay, now this is a marathon. This case was very tiring. Yes, I'm a pediatric dermatologist. I see cases up to 18 years old, but in this case, he's 18 years old, and I was on call. So they called me at that week, that dramatic week. For this patient, when the residents to send me the photos, I went to see the patient. He was young. He was clever. And he gave a good history of their current blisters over the dorsum of the hand that lasted almost 8 to 10 months before. It was tense. It started the day before in جانا في الإR كان لسه اليوم اللي قبله جاي طلعت له. He explained that this was on off for about almost a year with no clear trigger. This is the 4th episode. The last episode was about 3 weeks prior and managed in another hospital. That was a red flag, another red flag, because with time, he was just shopping between hospitals. That was a bit difficult for us. And for each episode, he would go to an ER for evacuation of the blister and IV medications. He mentioned antibiotics, he mentioned analgesia, according to the patient. No other body area involved, no mucosal symptoms, no history of medication use, history of significant weight loss. Now, here we said, okay, now we need to take this seriously. He has history of weight loss, history of epigastric pain, fatigability, dizziness, and epistaxis. So he received 1 dose of IV morphine in the ER, and we did some labs. So what do you think this could be as a first impression? A single bullous lesion over the dorsum of the hand that comes and goes at the same area for about a year. Fixed drug eruption. What else? Okay. Artifact. Okay, what else? We thought of as well some bullous mastocytoma that could be as well. He's in a tertiary hospital, so we need to think of everything. So we did all the investigations, the skin biopsy and cultures. Patients came to the clinic because I've seen him in the ER, but then أعطيته موعد عندي في العيادة. He came a few days later. The lesion improved, the pain subsided, blister was evacuated. That was good. Punch biopsy showed eosinophils and neutrophils. We waited for the DIF as well. The impression was subepidermal blister with minimal inflammation, blah, blah, blah. Nothing concrete. The labs came back negative as expected. Wound and tissue cultures were negative. The DIF came back negative as well for IgA, IgG, and IgM, C3 fibrinogen. We did the stains for CD1117 for the bullous mastocytoma, HSV negative. We did everything. In view of a negativity, we thought it could be drug eruption, as we mentioned before, partially treated EB. EB was just there just for the sake of it. We didn't really believe in it much, but we didn't want to miss anything. When he comes to our clinic, we are very, very vigilant. We do not want to miss anything. And he was negative for any lymphadenopathy. So before his next follow-up, the patient came twice in an أعطيته موعد. At that time, he came twice to the ER for the same complaint, and he did a big and huge fuss and received an analgesia, then signed DAM and leave. So next follow-up was 2 weeks later, healing erosion with the dyspigmentation. Assessment at this point was possibly drug eruption versus artifact, of course. And at that time, I received another call from a colleague in another hospital and told me, Abdullah, do you see this patient? Because he submitted a complaint and he did a huge fuss and مدير المستشفى مسوين مشاكل because no one is taking care of him, no one is taking him seriously. So, and I did a biopsy and it was inconclusive. So when I tried to do the biopsy, he was very stubborn. I managed to convince him. So it was a bit hectic. We requested further labs for him because he's very smart, and he was trying to throw information everywhere just to try to prove that this is this is somehow pathological. And we even ordered for urine porphyrins. We thought of porphyria. Who does that? We went so far. We did not want to miss anything. So we were so concentrated on this. But what happened is he refused to do the labs. He refused to do. 1 month later, he came again to the ER, same complaint, recent onset blister with no clear cause, received analgesia, x-rays unremarkable, urine tox screen was positive for amphetamines, the negative for cannabis. Now, at that time, I was disappointed. So I just asked the residents to leave. I asked the father to leave, and I sat with him. And I was a bit firm, and I said, look, I know that you're playing. We all know this. And look, I'm on your side. And we want this to stop. And he was a bit responsive, and he said, yeah, عندي مشاكل في البيت وما حد يعني. And then he stopped suddenly. He was like, no, everything is fine. I'm good. Why don't you believe me? I said, look, let's cut a deal. خلينا بس نتفق على شيء بيني وبينك. I will try to refer you to someone to talk to. At least لا تكلمني أنا ولا تكلم أحد. تكلم أحد متخصص. He agreed to do that. I thought that was triumphant for me, but he never attended again. And after that, he never ever showed up. Not here, not in any other hospital. So, I mean, it was just heartbreaking for me to see a patient at this age being so smart in the wrong way and deceiving all of us and trying, I mean, even our resources were gone. We did everything for this. Case number 4. This is a bit it's a bit easier, but it was a nice case. An 8-year-old boy who presented with this slowly growing lesion over his right ankle, which he had since birth. It's asymptomatic. If you can see somehow multilobulated plaques overlying terminal, there was some sort of hypertrichosis. What do you think it is? It's somehow fatty in a way. في شعرة فوقها شوية. What do you think? عفوا? Smooth, yeah, muscle, yeah, why not? But smooth muscle hematoma, that's what we thought. But it's somehow, there's some hypertrichosis. So it doesn't really go with it. Like smooth muscle hematoma, and if we have hair over it, but the hair gets erected because of the muscles. It doesn't have hypertrichosis per se. It's just that the muscles, when it contracts, the hair erects. So is it still smooth muscle hematoma? What could it be? It's a bit, when you touch it, it's a bit like fatty. It's not. Huh? Okay, that's nice. But hairy? Is it hairy? You can. Yeah, we thought of that. We thought of smooth muscle hematoma. So we did a biopsy. We thought of something called nevus. We'll talk that. So this is the biopsy. It came back. A basket weave hyperkeratosis of the epidermis with underlying infiltration. They had unremarkable fat cells which comprise about 70% of the dermis. Adipocytes were aggregated around. 2 unremarkable hair follicles were observed, and the elastic stain was normal. This was the diagnosis: nevus lipomatosis cutaneous superficialis. We're thinking of that. We're thinking of smooth muscle hematoma, and we're thinking of plexiform neurofibroma. But the thing is that nevus lipomatosis cutaneous superficialis doesn't have hair, doesn't contain any hair. The smooth muscle hematoma does, but it's the regular hair. So what we do, I guess, in dermatology, most in pediatric dermatology, when we have manifestations of different diseases, we just lump them and name a new disease, and that's what we did. It's a nevus lipomatosis cutaneous superficialis, but it's the hairy type, and to our knowledge, it's super rare. So you have the classic form, the solitary type form, and the classic form. It's mostly depending on the date of appearance and the location. So our case is mostly early and lower portion of the back and lower extremities. The presence of hypertrichosis in our patient is a unique feature. The best of our knowledge, it was only reported once. So that's why we find it interesting. And we did publish this case in JAD very recently, like 2 years ago. And it was nice if you want to take a look. Am I done? I think I have one case. Do we have time? We have time? One more case I have.
Still.
I can go? Okay.
Yes, you can.
So this is the last case. a 5-week-old Syrian male patient. It was somehow heartbreaking to me because they were referred to my clinic for my opinion on skin lesions over his skin by the ophthalmologist. The boy was born full term without any delivery or postpartum complication. The mother denied any relevant exposure and any prenatal or postnatal complications. The parents were not consanguineous, and no similar cases have been seen in the family. He presented like this. Yeah, and he had aplasia cutis over the right ear, aplasia cutis over the back. He had a microphthalmia, almost no eye over the right eye. Abophthalmia, which is an extrusion of the left eye, and multiple tags or colobomas over the right eye and nostril. What I used to say is, for residents, this is very important because we have a whole chapter about aplasia cutis and the associated syndromes that come with, and this is one of them, a super, super rare kind of it. And the thing is that we in dermatology, we diagnosed this patient. It wasn't the other way around, and we diagnosed it very, very early at 5 weeks. So this is called ocular cerebrocutaneous syndrome, which is called Delman syndrome. It's a super rare condition. It's a neuroectodermal disorder characterized by congenital anomalies affecting the skin, eye, and central nervous system. It was known as Delman syndrome after the physician. The exact genetic mutation is not clear. Now, this patient, I had access to genetic analysis in our facility, but the problem is that he needed to pay for that, and it wasn't possible at the time. I tried to help him with that, but he just decided to leave the country, and I think he just gave up, and I think it's one of the cases that really got to me. So there's increasing evidence of the role of postzygotic mosaic mutations in one or more genes, with the syndrome possibly being inherited as an X-linked recessive. That's why we see them more in males. It's often diagnosed in the first 2 months of life, and we diagnose it at 5 weeks. So we're diagnosed in childhood, whereas serious complications have developed. In addition, close to 20% of these could die. And I think the parent he just told me that, I'm just waiting for him to die. That's why it just got to me. And yeah. Patient did not show any neurological abnormalities on examination. However, long-term follow-up evaluating for developmental delay, intellectual disability. And we did as well report this case if you want to take a look for any further details. It's just, again, to make sure that aplasia cutis is something that we sometimes overlook. We don't know it, and it comes with many, many syndromes that we can avoid early if we diagnose it earlier. Thank you very much.